Good morning to one and all present here. I am presenting Iceberg on behalf of Medicine 2. Mrs. S, 60-year-old postmenopausal woman, chief complaints of fever since 2 months, fatigue since 2 months, passage of black tarry stools since the past 15 days. The fever was a low-grade fever without chills and rigors, and it was intermittent in nature without a documented temperature. This was associated with fatigue since the past 2 months, which was insidious in onset, progressive in nature. Since past 20 days, her activities of daily living are also affected. Like she says that she's not able to do her household chores and she resorts to staying uh, because of fatigue. And there is a loss of weight of about 10 kilograms with loss of appetite. There was history of passage of blackish tarry stools since the past 15 days, about 4 to 5 episodes per day. However, there was no alternating constipation, fresh blood, or hematemesis, or dysphagia, axillary or neck or breast swellings, no postmenopausal bleeding. So she was admitted with these complaints elsewhere and was diagnosed with severe anemia. She has received a total of 4 units of blood transfusion. And her labs, there was ANA 1 plus, so urine protein of 1 plus, and outside they have pulsed her with methylpred and was started on oral steroids. Gastroscopy was done, and that was reported as hiatus hernia with antral gastritis. There was no family history of malignancy. Vital signs. The positive findings mainly there was a temperature of 100 Fahrenheit and there was pallor. There was severe pallor when the palmar creases pallor was present. Breast and thyroid examination was normal. There was no lymphadenopathy. And uh, only that the visible pulsations was present in the cervical region as well as the suprasternal region. No organomegaly per abdomen and per rectum blackish tarry stools were present. The differentials that we considered at this point of time was first considering her age, her postmenopausal nature, uh, the syndrome of fatigue, loss of weight, appetite, low-grade fever with melena. Was a malignancy, solid organ, primary like upper GI like gastric malignancy or a lower colorectal malignancy, or since she was having chronic diabetes for 10 years, we thought if it was a CLD with HCC causing melena or metastasis as her age, ovarian or endometrial carcinoma, and hematological like leukemia, lymphomas, and infections like HIV with opportunistic infections. Bacterial disseminated tuberculosis was considered. Autoimmune, though less likely, IBD was also considered with constitutional symptoms. Her blood investigations, CBC, it showed a bicytopenia in the form of low platelets, 25,000, with hemoglobin of 3.9 with microcytosis. And her peripheral smear showed leukoerythroblastosis. The differentials for leukoerythroblastosis is probable a marrow infiltration because of metastasis or leukemia or lymphoma, or inflammatory disorders with sarcoidosis, which can infiltrate the marrow, which is less likely in her case, or a myelofibrosis, but that also was less likely because there was no massive splenomegaly or a severe sepsis. And her LFT, it showed my AG reversal of total protein of 5.5 with albumin of 2.7 with alk phos being 371. Her urea and creatinine were elevated, but the bun creat was 46, suggesting a pre-renal, most probably because of the GI bleeding. And INR or APTT was slightly deranged. As part of anemia workup, the reticulocyte proliferation index is 0.4, which was a hypoproliferative marrow. And the LDH and uric acid were elevated. BBVS was negative. Considering the possibility of malignancy, CEA was sent, which was elevated. But over the next subsequent days, this happened. Like there was a pancytopenia, like all her blood lineages started coming down. What are the differentials that we consider at this point of time?
Any of the PGs want to answer? Maybe some of our first years? Is anyone here? No.
So at this point of time, we consider the differentials of
first year PG. You want to just make a guess?
At this point of time, the cystocytes had also
So she had fever for 2 months and she had some bleeding, GI bleeding, and now she has a pancytopenia. From that initial list of differentials, are some of them more likely now? Severe sepsis, okay.
So she is based on the background history when all the lineages were involved. The differentials at this point of time we considered was probable DIC, and then if it is a TMA, which is less likely, or HLH syndrome, or the underlying marrow infiltration that is causing this pancytopenia. I would like to discuss few points and how we differentiate and come to the answer. So we sent the DIC workup. Fibrinogen was 165 with D dimers of 24,641. Triglycerides were 600 with ferritin of 203. Her LFT and RFT parameters were normal. So as we know, DIC, it is a syndrome that is characterized by activation of the coagulation system because of expression of the tissue factor by tumors or a gram-negative sepsis or any other inflammatory process that causes a diffuse thrombosis with consumption of all the coagulation factors with secondary fibrinolysis. As a result of this, our D dimers as well as our fibrinogen will be consumed and it will be less. On the other way, the second differential that we thought was if it was a TMA because the cystocytes started increasing. But in TMA, the underlying pathology is platelet activation because of Shigella toxin HUS or an alternate complement system because of atypical HUS or a deficiency of ADAMTS13 that causes von Willebrand factor multimers that causes platelet activation. But the entry point in TMA is a microangiopathic hemolytic anemia, which was absent in our patient. It was a hypoproliferative marrow, low reticulocyte proliferation index with no evidence of indirect hyperbilirubinemia. However, LDH was elevated, which can be explained by the lysis of the tumor cells. And the differences between TMA and DIC, the need to differentiate is the treatment is different for both. So in TMA, there will be a microangiopathic hemolytic anemia, and the organ failure predominantly is kidney and the CNS. So in kidney, we call it as HUS, and CNS is TTP. And in DIC, there will be a hypotension shock as well as lung involvement. And the blood pressure is found to be little high in the TMA category, whereas blood pressure is low in the DIC category. And the fibrin-related markers in prothrombin time as well as the INR, all of them will be elevated in DIC, whereas most of TMA, it will be normal. And the third, we thought if it was a HLH syndrome, she had only fever with cytopenias involving more than 3 lines, and there was a hypertriglyceridemia of 600. However, there was no splenomegaly on examination, no hepatitis, and ferritin was 200, and fibrinogen was 163. Bone marrow examination was not attempted at that point of time because she was tachycardic and she was in anemia and failure. And is there any criteria for a score for DIC? This was a score. This is ICTH score, table from Harrison. The sensitivity of the score is about 91% and specificity of 97%. So in our patient, she had a score of about 5, which fitted into overt DIC. She had platelets of less than 50. D dimer was severely increased. The prothrombin time is less than 3. Fibrinogen was less than 1, and total score of 5 was there. So the importance of the score is that if it is less than 5 and clinical history we are thinking of DIC, then it has to be repeated every 1 to 2 days. And if it is more than equal to 5, it has to be repeated daily to assess the critical changes. So the other doubt was the fibrinogen was 165. Can DIC have a normal or a elevated fibrinogen? Based on the study, it has been found that in the study, which was done in Los Angeles, fibrinogen levels were reportedly normal in about 57% of the study subjects. So it is said that it is an acute phase reactant and its plasma level can remain elevated. Therefore, hypofibrinogenemia for the diagnosis of DIC carries very low sensitivity and it is associated only with severe forms of DIC. So in this patient, after this, we had done a CT after she was stabilized. So she was basically in DIC. We've done CT abdomen pelvis, which showed a diffuse circumferential asymmetrical wall thickening involving the splenic flexure as well as a descending colon. And over the course in the hospital, she had 1 day of 3 to 4 episodes of black tarry stools, and she developed constipation, and she was developing features of large bowel obstruction. This was probably secondary to the neoplastic etiology. Bone marrow, which was done later, showed necrotic marrow with scant atypical cells, which is metastasized, suggestive of a colorectal carcinoma. So the final diagnosis was a stage 4 carcinoma colon with metastasis to the liver and bone marrow with a large bowel obstruction and patient in DIC. So colorectal carcinomas metastasizing to the bone marrow is a very rare presentation, and this was one case report that was published in Indian Journal of Pathology and Oncology. But here the patient presented with bony pains and CBC showed anemia and thrombocytopenia, and on the routine workup, it was found of lower GI malignancy based on immunohistochemistry. So in our patient, blood transfusion was given, FFPs were given, and antibiotics was done for covering the sepsis. And as she developed an acute large bowel obstruction, it was a high risk procedure. It was informed to the relatives about laparotomy and bowel resection. But when the relatives were explained about the prognosis, the risk and complications, they were not willing for the procedure and they were wanting conservative management. They took her to hometown. So learning points, first leukoerythroblastosis, when it is present, the differentials we consider, and DIC, ICTH scoring for DIC, and management of DIC. Thank you.
Thank you, Dr. Shirthi. Thank you, Dr. Shirthi. Are there any comments or questions from the audience? So what I thought about it is, first of all, DIC is usually not a primary disease. It's usually secondary to something else. So even if it is DIC, that is not the main problem that this patient has come with. So I think that identifying that is, in a way, treating DIC is like supportive care, but identifying the etiology is the most important. And some of the things like the D dimer being high can be there in any malignancy, and therefore it's there in her. So I'm not sure if, though the patient, okay, I'm not saying that a normal fibrinogen rules out DIC as you have demonstrated, but was that the main problem? Was that what caused her fever? And her bleeding as well may have been partly related to the malignancy, though I understand that the colonic malignancy does not typically cause melena, especially in the descending colon. So maybe that was a GI bleed that was related to coagulopathy, but I'm not sure of I understand that you are talk to us about DIC, which is fine, but the broader clinical picture of the patient is maybe not explained by the diagnosis of DIC alone. Of course, you came to a disseminated malignancy. And the other thing is, you mentioned that there were some suprasternal and supraclavicular pulsations, which I was waiting for it to be explained.
Probably anemia, heart.
Okay, just the anemia. So the carotid pulsations were prominent.
Yeah.
Okay, sure. All right, thank you.